I welcome you to the second session. And last time when we met, we were discussing about problems. Okay. We all have problems in our professional lives and in our personal lives, but we cannot get scared away from problems. We have to learn to fight the problems. As the environment is changing, as the face of the problem is changing, the aptitude, the attitude, and the approach to problem solving has to change along. As we know that, when we used to travel in the buses 40 years ago, there used to be pickpockets who used to, actually pick your pocket physically, take the purse from your trousers. 30 years now later, 40 years today later, we are doing the transaction through mobile, but there are still pickpockets. They have matured, they have advanced themselves to the circumstances, to the environment. So that was a negative example, but a wonderful example to problem solving. So with this, I bring you to today's session, a very important session today. Today we will be focusing on the whys of the problem, to get deep into the actual cause so that we can attack on that cause and give a permanent solution to the problem and not only control the symptoms. It will be wonderfully shared with you by Dr. Pratibha and Dr. Manoj. Dr. Mohan will thereafter bring out some relation to the actual real world in which we are living in. So the challenges exist, they will keep happening. We need to keep adapting. With this, Dr. Salil, good evening to you. I also ask you that, regarding problem solving, regarding this real world, any thoughts from your side?
Good evening, everybody. Commodore Raman, the problems will persist. Every time we start doing something or we are sitting somewhere, there are problems. And the problems, they do not tell you in advance. They are there. They come in front of you anytime. But we should know how to handle it acutely or chronically, whatever it may be. तो हमको उसको सॉल्व करने के लिए उसका रूट कॉज एनालिसिस जो आज आप बात करने जा रहे हैं, the thing which we all are going to learn today or to listen from our faculty, we should understand that आपकी परेशानी क्या है. यदि आप उसको बेहतर तरीके से समझ लेते हैं, मेरे ख्याल से उसका आप आंसर बहुत अच्छे तरीके से निकाल सकते हैं. जैसे कोविड और टीबी, ये दोनों हमारी परेशानियां रही हैं. कोविड में हमने देखा था कि हमारे सारे टीबी के वार्ड्स जो थे वो सारे एक्चुअली एक्वायर कर लिए गए थे फॉर कोविड, और टीबी के लिए हमारे पास पेशेंट्स का नहीं था और हमको समझना जरूरी था. एंड इनफैक्ट इट वाज अ चैलेंज विद अस, एंड वी स्टार्टेड सर्चिंग फॉर सम न्यू वार्ड्स फॉर आवर पेशेंट, एंड वी हैड an answer because we cannot run away from that problem. आप उस प्रॉब्लम से भाग नहीं सकते, लेकिन आपको उसको सॉल्व करना पड़ेगा. Over to Commodore Raman, please.
Thank you, Dr. Salil. Very wisely stated. At the same time, I also welcome Amit Zas today, Dr. Sood, DTO Kangra. He's been associated with us and he will also be sharing his views. And I also welcome Dr. Mukta Rastogi amongst us. She will also be sharing her views. And with this, I invite Dr. Manoj Jain and Dr. Pratibha Kohli to take this session further.
Thank you so much, Commodore Raman, and welcome everyone. And good afternoon to you all, and good morning to you from US. It is early morning, 6 a.m., but it is so delightful to be with you and sharing with you the learnings. What we will talk about today is going to be the core of the tool of what Pdsa is. So with that, my co-presenter, Dr. Pratibha, glad to have you. And let us talk about what we're going to be doing today.
So we are going to understand very fantastic tools today. First, we are going to understand how to identify the problem, how to make the aim statement, and if we are making the aim statement, then how to measure it, and how to chart the process map, and like Ramanji said, the problem solving, the RCA. That's what we are going to do it today. So I hope this will be a very interesting lecture, and we are going to thoroughly enjoy it.
Absolutely. And I can promise you, you will be transformed in your thinking in the next 90 minutes. So that is clearly what we have done again and again. I have done these cycles for over 1,000 times. And each time I have found my fellow colleagues who have done this to say, wow, they have had that wow moment. So let's begin. Okay, everyone has a problem. Yeah, aapne suna hai, you have heard this from Commodore Raman, you have heard this from Dr. Salil. How we address the problem is the key issue, and how we solve it. Each day we're solving it. Ghar ki problem hoti hai, ya bazaar ki problem hoti hai, ya kaam ki problem hoti hai. We solve those problems. How we solve the problem. There are multiple ways. Each has a different style. What we're sharing with you is an evidence-based, systematic, scientific methodology. So if we have the next slide, what is the problem we're facing right now? Without doubt, I think you will agree in our TB program is that notification have dipped down. No issues, public and private. What we need to do is to try to focus and see how we can bring this up in each and every state. And we know that this relates to 30% of our subnational awards. Now, here is an example. And if you have the previous slide, we have Dr. Sood, who will be a guest lecturer. You've heard that. So just, sorry, go back. Yeah. And we're delighted to have you, Dr. Sood. We'll be hearing from you and your experience as well. And most certainly, you will be adding a great amount of insight into the problem and the solutions as well. So let us look at the problem in a graphical manner. So if it's next slide, this is what I really want all our DTOs to think and look towards and approach. Isme, what we notice is that we were doing fairly okay in the baseline. Look at the yellow line. I know you've seen this slide before. What we want to do is to have you create this slide for each district, for your own districts, and look at it and ask yourselves, why can we not increase to what we were in 2019? The pandemic has taken us down and we need to boost it up. And that is what the problem is, that we are not having enough notification. Realize this, if we do not have enough notification, the ultimate 3-5 years trajectory means that we will not be able to reduce the incidence of TB. So problem, reduce the number of notifications, and we need to address that in order to bring down the overall TB rate. Okay, so we know the problem. So Dr. Pratibha, how are we going to approach it now? How are we going to approach the problem?
So we like you said, it is we are going to use a scientific approach. So if we are going to use a scientific approach, we are going to use a scientific tool. And like we discussed earlier in BTN 1, we have introduced you about the model for improvement by IHI. So we basically ask 3 questions before we start the PDSA. So first question is, what are we trying to accomplish? What we are trying to do, what is the problem? That's what we ask. So if we ask that question, we get the problem statement. We get near to something which is creating problem for us. We are articulating the problem. That's what we are trying to do. So when we try to do, we ask some questions. So here I will ask Dr. Sood to share his insights with us. So some helpful questions will be like, what is the problem? Dr. Sood, what problem you faced? Yes,
Good
Dr.
evening.
Ram.
So, since the last 2 years with the COVID situation, what we saw was that TB notifications suddenly dipped down.
Okay.
Though we are trying to achieve higher and higher notification, but due to collapse of services, we
Okay.
found in Nikshay we have a Nikshay dashboards. So that
Okay.
dashboard is a graphical representation of all our performance parameters, and from those dashboards, even any layperson, any administrator can understand that this is a big problem. So like TV notification dipped down in the last 2 years, and this was a very big problem, because if TB is not notified, it's going to spread and it's going to increase further. So
That's
that was a
right.
very big challenge.
Right. So you are saying the problem is the low TB notification in total, and we got to know about the problem through Nikshay data, which was showing the decline, which we are just going to share with you. And you said that last 2 years you have seen the dip, and because of this dip, we face the effect of it, that the patients were getting missed. So this is the data you are talking about, Doctor?
Right. This is the dashboard which we get from the Nikshay.
Yeah.
And you can see that after the first quarter, suddenly there was a huge dip. Then when we had these lockdowns, April, like it was
2020.
like even it went down to even just 1/4 of the notifications.
My God.
Yes. So that was a huge concern that you had a big dip, right?
And like 2021 graph, we can see that when the second wave came up, and around April, again we had a huge dip, and like the effects of the strategies which we did to recover, that's again shown, the graphs again went up. So the Nikshay data is a very good tool to routinely monitor our performance.
Exactly. Excellent. So you have identified the problem. So how do we go, Dr. Pratibha, from the problem to our aims? So our first goal as DTOs is going to be creating an aims.
True, absolutely. So we have identified the problem, that is we have low notification, but now we have to go with the aim statement, which has to be scientifically correct and measurable. So how we are going to do that? We are going to use this particular format to make the aim statement. So what it says about where will the change be implemented? What are you trying to change? By how much will you change it? By when do you want to see the change? What will you do to make the change? So I will ask Dr. DTO Uttarkashi to basically help us. We did it yesterday, the aim statement. So let's do it live. It's very easy. All of us can do it. So you will see the ease of how we use it. So the problem statement, like we said, it is problem is low TB notification. DTO Uttarkashi, are you with us?
As she may be coming along, what you may want to do is just expand the percentage a little bit on the screen so we can see it a little bit better. So all you're saying, Dr. Pratibha, is that we need to fill in the blanks. मैं जब छोटा था मुझे ये करने में बहुत मजा आती थी और it was fill in the blank was one of my favorite things to do. But you're saying now we can fill in the blank, and then how does that play out into creating our aim statement?
I'll show you. It's such a beautiful tool. You will see the ease of it, like where the change be implemented. The change be implemented in your district. Like I'm going to enter Uttarkashi.
Okay. So you're doing this live.
Yes, right? I'm doing this live, and you will see the aim statement getting ready alongside. Okay. So what are
Uttarkashi is there? DTO Uttarkashi is there. It'll be good fun if she is able to participate.
Please check, Dr. Uttarkashi. Yeah, it's okay. So what are you trying to change?
So what we're trying to change is to increase
Yes.
TB notification. Yes.
Increase, because our problem statement is low TB notification. So we are trying to increase the TB notification. That's what we are trying to change it. But how much you will change it?
I see 5%, but you know, I may want to change my mind after this. Let's say
Let's be
5% right now.
conservative in that and not go, 20%
Yes.
and 30%. Let's say, okay, 5% will go
5%. Okay.
slowly.
Got it. Got
Yeah.
it.
So
Keep going.
and by when
Yeah.
do you want to see the change?
It's from DTO Uttarkashi is there. Yes. Yes, please. Yes. Come on in.
सर हमारा जो नोटिफिकेशन का जो प्रॉब्लम मेन प्रॉब्लम है
जी बोलिए. हाँ.
एक तो हमारे पास प्राइवेट सेक्टर जो है ट्रस्ट नहीं है. ओके सर.
राइट.
और इसको हमने हेलो
बोलिए.
जी हम सुन पा रहे हैं डॉक्टर साहब.
हेलो
आवाज आ रही है?
हाँ आवाज आ रही है.
हेलो
सर
आवाज आ रही है क्या मेरी?
जी आ रही है. जी आ रही है.
हेलो.
हाँ आ रही है. बोलिए. हेलो. हाँ आवाज आपको हमारी नहीं आ रही होगी.
I think he is in a poor network zone, so it's okay. So when do you want to see the change? It's 2 months. We want to see the change. So we are conservative regarding the 5.
Yeah. So let's go see the yeah.
So in 2 months we are going to change it. Okay. And what will you do to make the change? So we have decided that we are going to sensitize the ASHAs, the chemists, CHOs, and number of referral done. So this is what we are going to do. So see, when I change this, see, I am changing it live, okay, in front of you. So when I change it, we are getting this aim statement. In Uttarkashi, we will increase total TB notification by 5% within by 2 months using sensitization of ASHA, CHOs, and chemists, and number of referral received. This is the ease of tool.
I see that it fills in automatically. I want to change that 5% to 10%. Can you do that and see what happens to the aim statement?
Yes.
Let us see 10%.
See, it is changed. It is 10%.
So go ahead. Now I see the aim statement down there by C. It's changed to 10%. I see. So this is a autofill, a great tool that will allow you to do that. And as I see it, the remaining parts of this also, which we will go over later, are process maps, run charts, also autofill. That's why we're calling this a electronic PDSA tool. It is our unique strategy from CETI that has been incredibly helpful. Okay, so now, Dr. Pratibha, we have an aim statement, right? Absolutely. We have an aim statement. What are the core elements that make it smart? Tell us that.
So you need to remember only one thing in your mind while you are making the aim statement. You just remember one word that is a mnemonic, which is SMART. SMART stands for to be specific. Like all of you have seen, it was specific. It was telling about the problem. It was telling about the month. It was telling about the percentage. It was telling about, what you are going to do. So it was absolutely specific. It was measurable. How much? 5%. It is achievable. In 2 months, we are going to achieve 5%. Doable, conservative. And it is reliable, relative, realistic, and time bound, which we said 2 months. So if you remember this SMART, you will never go wrong in making your aim statement, because if your aim statement is good, half battle is already won, because you have created the title, and you are going to work on it. What do you say, Dr.?
Yeah, so this is exactly the point, which is we have to be very specific and measurable. अपन कई बार बोलते हैं कि हाँ मुझे नोटिफिकेशन इम्प्रूव करना है, पर कितना इम्प्रूव करना है? जब तक अपन नहीं करते. I'll relate this example. If I want to reduce my weight, I've been on vacation for a little bit and have gained 5 pounds. So I say, oops, I have to now reduce by 5 pounds. I have a specific measurable goal, and that makes all the difference in the world. Okay, so now
And
let's
5
talk
pounds in how many weeks?
exactly. Right. So we can have to do it how many weeks? So make it time bound as well. And you have to make it realistic. It's not like overnight, next day, you're going to be able to do that. Same thing applies with this. But now let us go into how we do the measurement. Measuring weight is very easy. It's a simple one-time process to doing. But measuring is a complicated art. And this is what we want to help our DTOs understand is choosing the measures and what types of measures is really important.
Absolutely.
So what are measures? Yes.
Measures are basically which is taken before, during and after the project. It is you can say remedial measures. You can say that to understand the problem we are taking some steps, so those we called it measures. So beforehand it provides the baseline, means how many things, means how many numbers it's been done, which any improvement is being measured or not. So this is what we call measure. We are measuring against something. So this is measure. What do you say, Dr. Manoj?
Yes, absolutely. So आप सब जानते हैं measures, that's not the big deal. But I think what the big deal is let us break them down into 2 core types. There are multiple types of measures, but 2 core type of measures जो अपन को बातें करनी है, that we want to help better understand, because this will determine how we approach the problem. And they are called process measures and outcome measures. And let us see the difference between these 2. Okay, so what is a process measure? You see, we all live in a system. Yes, go ahead.
So process measures are basically when we talk about the processes. We all have processes laid. We all have guidelines. So when we are following the guidelines, the system processes, and we are following that step as planned, those are called processes. When we see any variations and we need to, do something, we call it, we have taken the measures.
Got it. So process measures are steps.
Yes.
Okay. So if process measures are a step, and let's take an example of this to better understand. So if we say our problem is that low notification, apan ne baatein kari, that is clear, or apan ek root cause, we'll get to other root causes, but ASHA workers are not referring patients adequately. Then a process measure is that we want to measure the number of referrals by ASHA workers. Now, this is different from our outcome measure. Okay, so number of referrals by ASHA is a process which will lead to an outcome that we are looking for. So it is important. You could be looking at other process measures as well. But if you decide you want to improve your outcome, what you have to do is to also focus in on the process. And if you have a measure for evaluating that process, as you do that and improve the process, automatically the outcome may come. कई बार क्या होता है कि मुझे मालूम नहीं कि if my weight will go down or not. But if I exercise, like yesterday, I decided I was going to begin my exercise routine again. I went swimming, I did all of these things. I said, I got to get the processes right. I reduced my diet content. Instead of eating twice, eating 2.5 rotis, I ate only 1.5 roti. So I did these processes so that my outcome, you have control over processes. You don't always have control over the outcome. That's the major difference. So now let us look at an outcome measure. So we talked about a process measure. Let's look at an outcome measure. And if you bring in the next slide, what that will show is what is an outcome measure. So Dr. Pratibha, yes. So if you have outcome measure is the result. And in an example, is the total notification. And it is what is often reported. Actually, जो senior level होते हैं ना, वो आपके process measure से concern नहीं है, वो बोलते हैं बस just give me the outcome. But they don't realize कि आपको और हमको जो काम करना पड़ता है वो process की domain में करना पड़ता है. और अगर अपन processes right नहीं करेंगे तो outcome right नहीं आएगा. So that is a critically important area that we need to make sure and understand. So an outcome measure is something such can be the number cured, number treated, or number who have died. So these are outcome measures. Okay, let us go back to our example. And next slide, what you will see is how we can put it. And I've added another process measure. Problem, we understand, low notification, root cause that Asha was not referring. We said one process measure was that number of referrals from Asha. We will follow that and see. And another that relates to intervention is number of Ashas that are sensitized. So I'm going to take an intervention and begin sensitizing Ashas. And then I know that that intervention, sensitizing Asha, will lead to the outcome, which is number of notification. So here what you can see is the relationship between a process and an outcome measure. ये concept really important है understand करने के लिए, क्योंकि आप जब अपनी aim statement बनाएंगे, उसके बाद आप you will be choosing a set of measures, and you need to be very clear on what is a process measure and what is an outcome measure. Process measure is something that is under your control. Outcome measure may or may not be. But if you do the process measures right, your outcome will come. Dr. Pratibha, would you like to add more on this?
Yeah, so process measure, like you said, it's the problem we have stated, and we got the root cause. We will explain how we come to the root cause. So in process measure means where the variations we are having, we have to plug in the gaps. And that is what we call the process measure. The remedial actions we are taking is the process measure. And that's where we have to take action and add in here as the process measure. So agar it's like you have the lock and we have the key. Until unless you put lock and key together, you will not be able to open the door. So it's like the process measures are the lock. So you need to use the key to solve the problem. So you need to use the process measures first to solve the problem. So we have Commodore Raman. He wants to say something. Raman sir.
Okay, thank you. Actually, DTO Borivali has raised a very important issue. And he says that, absolutely acknowledging that Asha is the one who are related to the community. And there are a couple of more chats which have come. And the query which has been raised is that, if there is resistance from Asha and if she is not able to deliver, would the PDSA be able to solve? So yes, DTO Borivali, the PDSA will give you solutions towards that as well and everything else. And we will be able to actually measure how much efforts are going in and how much outcome is coming in. And where is what is lacking? Exactly the PDSA process will tell you where is exactly the problem. Dr. Manoj, Dr. Pratibha, would you like to add anything?
Yeah, absolutely. So this is great. What then you have to do is do a root cause, which is exactly the next set of conversations we will have after baseline. Is what you will have to do is the root cause to find out why. Why is the Asha not working? Is it because, like Dr. Joshi was with us for a half-hour conversation yesterday? Dr. Joshi talked about, there will be issues such as Asha may be on maternity leave, or Asha in a given district may be on other leave. Maybe that is a reason. Maybe there might be not a group of individuals who are trained enough. So what we need to do is to find out the root cause. And the thing is, only you, the DTOs, because you are the key people, will be able to do the root cause. STO nahi kar payega, even DDG cannot solve that problem. That root cause problem can only be solved at the DTO level. And that is why it is so critical that you take this thinking of process and outcome measures and root cause and solve that problem. So perfect example that yes, if the ASHA is not getting sensitized, we need to find out why. If not, they're not referring, we need to find out why. Great, great question. So if we shall continue how to choose a measure, I think it's going to be always important that you don't overstretch yourself in choosing a measure. So Dr. Pratibha, we've talked about this. If you were to choose a measure, what are some things you want to keep in mind?
So firstly, I'll always think about that I'll choose something which is already being measured because it will be easy for me to take decision. So I'll choose something which is being measured.
Right.
Second, I'll see something which is tracked over short time,
Right.
days or maybe weeks, but definitely I will not venture into something which will take months or years, because when we talk about this, our data
Right.
gets, that the importance of it, we lose the momentum. So we
Got it.
want to take something which is important for the days and weeks.
Exactly.
And
So yeah. So your internet, it may be a bit slow and you're cut out. So I'll speak on your behalf. What we need to make sure is, hey, it's easy to measure. Don't create measures that are not easy and not readily available. You track them over a short period of time. Why? Because we don't want to wait for 5 years to figure out that did our impact or did our intervention work or not. We need to know over 5 to 10 days of time if that is working or not working. And make sure that you have an outcome measure along with the process measure. If you only have one, then you will not be quite effective in that. So with that, let's continue. And we are, as you can see on the next slide, that we have our model for improvement. What are we trying to accomplish, which is our aim, and how will we do this? We need to measure, and then we also talk about what changes we will make. These are interventions. So these are questions that we ask to move ahead. Yes.
Right.
I think we're tight on time. Yeah, we may want to, yeah, go ahead.
So like this is our second question, how we will know that change is an improvement, we need to measure. So why we are telling you again and again, because we need to remember these questions to answer the problem, right? So now let us go to the next slide, which is absolutely time for polling. So Computer Ji, can we have a polling question on screen, please?
So this is kind of a trick question.
Yes.
We gave you a lot of information.
I don't think so. Yeah.
So you're saying specific, measurable, achievable, reliable, time bound, and you're saying it's achievable, action-oriented, and realistic are the new elements that you're putting in. So very good. You've got lots of people, and I see that many people have put in all of the answers are quite relevant, and
you are giving the cue, Dr. Manoj.
so excellent set of so we have to make sure that the goals are specific, measurable, achievable, reliable, action-oriented, and realistic. So all of the answers look quite correct to me. So good job, and great to have so many people participate and to let everyone know that that all the answers are correct. So super. Okay, Well, let us continue with our conversation, and let's do baseline measurements. Shall we continue with that? So if I'm going to know that there's an improvement, I need to know where that improvement is from, right? If I have gained weight, then I need to know where my baseline weight was, and then it has gone to a new level, and then to begin to reduce. So let us talk the importance of knowing the baseline. So if we continue, the concept of baseline, Dr. Pratibha, share that with us. You might be on mute, so let's talk. Yeah, go ahead.
I'm here. Yeah. So baseline concept is, like you said, we have something as a reference point. Okay, what we were before this day. Okay, that is what we call, in a simple language, is baseline. So we take a standard against you measure. So that is what is baseline. We also called it anchor. We also called it adaptation line. You beautifully explain with the example of weight what is baseline. So if we go forward, in next slide, you will see why to use the baseline measures. So we say that baseline measures basically we use because we want to be sure whether our efforts are going to be working or not. For example, if my weight is that much and I am unable to reduce it, and it is not healthy for me to reduce further, it will be wastage of resources. So I should have a baseline and help you make sense about something is complicated. It will definitely tell you about that what is complicated, what is not complicated about here in the baseline, and help you decide when to start an intervention. And also it will also tell you the intervention is necessary or not. Ramanji, do you want to add in here something about baseline measures? You have such a wide experience from different fields.
Well, thank you for getting me in, Dr. Pratibha. Absolutely. If I have to monitor progress, in fact, let me not call it progress, let me call it change. By putting my efforts, there has to be some change which will happen. How will I monitor that change? So I should have a benchmark, something which has happened before, to evaluate what my efforts are yielding. That is what is the baseline measures. Some measure on which I can measure whether my efforts I am putting, the time I am giving, the change in approach which I am making, if it is making difference, by how much. So I must have a baseline. It has to be a data. The baseline has to be a data. So if my efforts are working or not, if it is too complicated, do I need to simplify it to start seeing the effort and to start seeing the work? And also, if it is time to start the intervention, once the baseline data is complete. So that is all I can contribute, Dr. Pratibha.
Great.
So let us see a real live example, and let's go to our next slide. And if you see, say in Jaipur district, the baseline was about 2,000 notifications in 2019. That's where the close 1,900, 2,000. And then when the dip happened, we know that we changed from that baseline. Then, as you can see, a new baseline, about 1,200, 1,400 was there in July of 2021. And what is the problem again and again in every district is we still have not been able to reach that 2019 baseline and above that, which we know we need to achieve in order to bring the subsequent decline. So baselines change over time, and we need to know where we have started from to better understand. So this is a real life example. What we would request is all our DTOs look at their baseline over the past 2 years and reflect on how notification has changed. Why? Because this will help you understand how to increase notification in the next 3 to 6 months. History is what is incredibly helpful. We've learned this, that history often repeats itself. And so if we want to do better the next time, we need to understand that history, and the history is only a different word for baseline in many ways. So we've had a lot of conversation about measures. We've had a conversation ki baseline kya hai, what are baseline measures, and then we've also had an aim statement. But this other topic was, remember we talked about the ASHA workers and the processes that are leading to the decline. Let us talk a little bit about process maps. How do we look at this and the root cause? At that time, we'll bring in Dr. Rastogi in as well. So shall we talk about next slide on process maps and what and how they can help us find the root causes?
Okay, so if we talk about the process map is basically in simple language, I'll explain that it is flow work. Okay, how it is basically the steps, how we want things to be done one by one. So that is we call flow of work, or we can say it is series of event, or we can say it is a flow chart. That's what we called a flow, the process map. And if you see the next slide, you will understand why it is so important. So in flow chart and the process map, we basically use the process map to understand the entire event, entire process, that when we are starting, when we are ending, what all steps are required, what all people are required, where are the bottlenecks, what we need to do for the interventions. Everything is visible in that process map. It basically gives you insights what is going on. It is such a beautiful chart, which definitely Dr. Mohan will share his thoughts about it, and Dr. Sood will also share his thoughts about the processes. Process map basically spots the waste. It is also streamline the work. It builds the understanding in your team. When you are doing the brainstorming, you have everything in front of you. It gives you better understanding. You are enabled with more and more tools to use it and analyze it. So this is the power of process map, because we have documented each and everything.
Excellent. So I was just thinking, Dr. Pratibha, of an analogy. Remember, we look at data in an Excel sheet, or now you can just click one button called graphic, and it turns it into a bar chart, pie chart, or a line graph, run chart. That, just like that, data turning into a graphic, what the entire process map is activity turned into a graphic. Absolutely. And that is the same thing. And we have tremendous amount of insight. So I would invite Dr. Mohan Kohli. Dr. Mohan, help us go through an example of a process map of private patients' TB notification. And next slide, which will be help us to better understand how our DTOs are going through this thinking, and what the 150 or so DTOs who have done this before and thousands of others who have done this have looked at that. So if you next slide, please, and then we can continue with that. So,
Manoj, even before I get
Edwin,
into that,
if you do next slide.
Am I audible?
Yes, yep. Please go ahead.
Even before I get into that, while the next slide is coming, everybody will be thinking, why do we need to know our own process chart? We know how cases are notified, right? That's not the point. The point is, we know most of the, can we go to the next slide, please, Edwin?
Yeah. So while he's doing that,
While
let's
he's doing it,
continue.
but Manoj, why it is important is because we have many things in our mind, but sometimes when we put it down on a piece of paper, right, it gives objectivity to it, right? So whoever looks at it, we look at it in the same way. It shows us how a patient goes through the whole process, right from the symptoms to identification to referral. So what is happening over here is, there are a lot of ways in which a patient can reach the private practitioner, right? The patient by itself, knows about TB or knows about some symptoms, or is simply worried, will go to the practitioner, or it will go to he will go to a nearby person or a healthcare provider who might refer to a practitioner because he has symptoms of TB. Otherwise, he would have seen IC programs of the government, or attended a sort of meeting or something. Here he realizes, okay, either I have these symptoms or someone near me has a symptom. He might refer to the practitioner. What also happens in the private sector is a lot of times the chemists, the system works like that. Even the chemists where these patients go do refer the patients to the private practitioner, usually to whom they are affiliated. And what happens is even our NTP staff is sensitizing the private practitioners not to miss cases and to notify the cases. Once the patient reaches the private practitioners, the blue folder, the blue boxes, right, is a process through which the patient goes. The patient visits the private practitioner, which is followed by a history and examination by the doctor. Certain tests are prescribed. Most often, the private practitioners might do a chest X-ray upfront, and many of them would also do a sputum microscopy, which everybody would agree with me. And depending upon the results of those tests, the patient might be, either sent for a TrueNat or a CBNat and notified and started on treatment. Or if the patient comes out to be negative, even after that, then would follow another antibiotic course and probably a follow-up. But even in this process, Dr. Sood, I would like to bring you in over here. Now, chahunga ki you also throw some light on this. Even in this process, a lot of things can go wrong, right?
Right.
And that is why we need to know this whole process. So can we just have the next admin?
So yeah, Dr. Sood,
Can you
go
throw some
ahead,
light?
share your thoughts, and then I'll share my screen.
Yep.
Since the COVID has come, so there's the patient's felt need is the cough. It's not the TB. So patient has a lot of stigma to go to the hospital. मेरी testing हो जाएगी, मुझे उठा के बंद कर देंगे. So he goes directly to the chemist. They get a lot of WhatsApp knowledge on what medicine they want to take, or even the chemist will prescribe. So patients go to the chemist. They don't need to get it tested. They don't want to. So one of the biggest this thing is that we had huge sales of Dolo 650 and all those drugs. So patient goes here. Now our challenge is to get the patient from the chemist to the hospital and to the lab. So we are trying to use the informer scheme to get the chemist interested. This informer incentive is a peanuts for the chemist, but we are trying to create something like a value, like will honor you. So social capital is a much bigger thing for the chemist rather than the financial incentive. So even this patients visit the RMPs, patients come themselves. So there's a lot of delay in part of the patients. Patients neglect their this thing. To National TB survey, which came up just recently. So they're telling that 2/3 of the patients are still neglecting their symptoms. So one of the patient pathway big barrier is at this level, where we need to work a lot on the demand side. So you're totally right, sir. Like once we get the patient to the practitioner, then it's a bit easier. But within the community, working on the demand side, it's a very, very big challenge.
Absolutely.
Then, sir, even once the patient comes to the practitioner, उसके बाद भी कई जगह miss हो जाता है. We miss the patient even after that.
Definitely, sir.
At the diagnostic stage, your thoughts about between the diagnosis and the refer and the notification also there is a problem, right?
Right, definitely sir. 2 से 3 हफ्ते तो मिनिमम मीडियन डिले होता है, जो रिसर्च बोलती है कि जैसे पेशेंट्स के कॉन्टेक्ट्स आते हैं कि दे आर डैम स्केयर्ड कि इसको टीबी हो गया, अब हम क्या करें. वी टेल देम दैट नोबडी वाज डायग्नोज्ड ऑन डे 0. तो आपने जितने इन्फेक्शन होनी थी लेटेंट टीबी वो हो गई है फैमिली में, तो get yourself tested and don't discriminate. So there's a huge delay even after the patient reaches the hospital or the patient sample even reaches the hospital. तो कई बार ठीक टेस्ट प्रिस्क्राइब नहीं होते हैं. ये जो नेशनल प्रोग्राम वाले टेस्ट होते हैं, they are the lowest priority.
Yes.
All the tests which are expensive tests, those are the first priorities for the doctors. और ये फ्री वाले टेस्ट जो हैं वो तब होते हैं जब सारी चीजें वो रूल आउट हो गई, तो बोलते हैं अच्छा चलो इसका मलेरिया पैरासाइट भी करा लेते हैं, अच्छा स्पूटम भी करा लेते हैं. तो these things go down quite down the line. The index of suspicion is high and the what you call और अगर पेशेंट को टेस्ट प्रिस्क्राइब कर भी देते हैं तो पेशेंट जरूरी नहीं है टेस्ट करवा ही लेता है.
Right. And Dr. Sood, sometimes it also happens that the private practitioner is in a standalone clinic and does not have any diagnostic test. उसके पास है ही नहीं. So what happens is he will refer for the test somewhere else and the patient never gets the test because he will take some symptomatic treatment and not go to the for the test, right? So we might lose cases there also.
जो एट्रिशन इस लेवल पे होता है कि अगर सैंपल ट्रांसपोर्ट मैकेनिज्म नहीं है, पेशेंट को बोलेंगे वहां जाओ तो देयर इज अ ह्यूज चांस कि वो नहीं जाएगा. अगर वो चला भी जाता है, मान लो उसने दूसरे हॉस्पिटल को भेजा, सरकारी हॉस्पिटल को भेजा कि वहां चले जाओ, तो प्राइवेट प्रैक्टिशनर की पर्ची नोबडी विल ऑनर, तो उसको बोलेंगे दोबारा पर्ची बनाओ, तो पेशेंट फील्स हैरेस्ड.
So sir, what I understand, first gap is the patient not reaching the private practitioner because of various factors.
Right.
The second is even after he reaches, the doctor might not be able to notify.
Right.
And after that, it could be that the patient has, come there but not gone for diagnostics. So all these issues are a big challenge, right? So thanks, and I would like to hand over Manoj back to you.
Absolutely. So what we see is when we draw a process map, we are able to see graphically the problem, and then we can also identify the areas of solution, or intervention. So this is really important because we are now able to focus and pinpoint कि अपन को ये करना है. And then from there, you can make a very specific aim statement that relates. But let us go back to that core question of the root cause. If you remember, we had talked about कि ASHA workers were not referring. And then we said, but wait a second, we have to find out the root cause. So delighted, Dr. Pratibha, that we have Dr. Mukta Rastogi with us. She's been a wonderful DTO, have been very engaging from Himachal Pradesh. And Dr. Rastogi, we're delighted to have you here and to share some of your experiences in what you did in root cause at some of the problems that you were facing. And I know you've been honored with the bronze medal and for subnationals. And I want to congratulate you and all of the other DTOs who have been have achieved the subnationals. And I will say this: our wish, our dream is to have each and every DTO be able to achieve that. And I'm certain that with your efforts that all of you are doing, you will. So, Dr. Rastogi, share with us your thoughts on this.
Thank you, sir.
Yes.
तो सबसे पहले हम यही बताना चाहेंगे कि जब कभी भी पेशेंट हमारे पास आता है, तो मान लीजिए वो ये कह के आता है कि उसको फीवर है, तो पहले हम उसको सिम्टोमेटिक ट्रीटमेंट देके और पहले उसका इन्वेस्टिगेशन करवाना चाहेंगे. तो सबसे पहले हम जो है उसको इन्वेस्टिगेशन के लिए भेजेंगे, उसके बाद ही फिर हम जो है पहले उसका रूट कॉज देखेंगे कि उसको फीवर क्यों आ रहा है. तो इसी तरह से हमारे और भी जो प्रॉब्लम्स हैं उसमें भी हमको सबसे पहले उसका रूट कॉज एनालाइज करना है कि आखिर प्रॉब्लम किसकी वजह से है, क्यों उसको बार बार फीवर आ रहा है। इसी तरह से हमने जब देखा कि हमारा जो लो टीबी नोटिफिकेशन है वो कम क्यों है, जब कभी भी हमने डॉक्टर से अपने बात करी और उनके पास हम गए तो उनका ये कहना था कि हम तो स्पुटम एग्जामिनेशन के लिए लिखते हैं, लेकिन जब हम अपने लैब टेक्नीशियंस के पास जाते थे वो ये कहते थे कि भाई रेफरल बहुत कम है, हमारे पास पेशेंट आते ही नहीं है। उस समय हमने एक अपनी मैकेनिज्म डेवलप करी, हमने एक फास्ट ट्रैकिंग कार्ड हमने डेवलप करा जो कि हमने रजिस्ट्रेशन काउंटर पर ही रख दिया। तो जब रजिस्ट्रेशन काउंटर पर हमारे पेशेंट जाते हैं अपनी पर्ची बनवाने के लिए, वहां पर जो है वो पेशेंट से पूछा जाता है कि आपको किस चीज की प्रॉब्लम है, ताकि उसी ओपीडी में उनको रेफर किया जाए। जब भी कभी पेशेंट ने ये बोला कि उनको कफ है, तो फिर वो फास्ट ट्रैकिंग कार्ड जो है वो उनको पर्ची के साथ में दे दिया गया। और उसके लिए हमने उनकी जो हमारे होम गार्ड्स थे और जो हमारे डॉक्टर्स थे, लैब टेक्नीशियन थे, सभी का हमने सेंसिटाइजेशन किया कि जो कोई भी ये फास्ट ट्रैकिंग कार्ड लेकर आएगा उसको प्रायोरिटी पे जो है हमने देखना है। और एक और फायदा था इस फास्ट ट्रैकिंग कार्ड का कि पेशेंट डायरेक्टली अप्रोच कर सकता था लैब के लिए। तो वो जो है वो पेशेंट डायरेक्टली जो है वो लैब में जाकर अपना स्पुटम टेस्ट करवा सकता था। इवन इफ अगर डॉक्टर ने उसको प्रिस्क्राइब नहीं भी किया है, तब भी अगर उसको कफ के सिम्टम है तो वो डायरेक्टली अप्रोच करता है लैब में। तो इससे हमारा जो है वो लैब टेस्टिंग भी बढ़ा और हमारा टीबी नोटिफिकेशन रेट भी काफी इंक्रीज हुआ।
सो डॉक्टर मुक्ता, आप मुझे सुन पा रहे हैं?
हाँ जी, हाँ जी।
Yes, absolutely.
ओके, तो डॉक्टर मुक्ता, आपने बोला कि आपने ये देखा कि ओपीडी में प्रॉब्लम आ रहा है एंड पेशेंट जो है ओपीडी की लाइन की वजह से वो वापस जा रहे हैं, या फिर वो लोग उनको और लोगों को इन्फेक्ट ना करते हुए आपने एक फास्ट ट्रैक कार्ड यूज किया, प्रायोरिटी पास दिया। क्या आपने अपने जो होम गार्ड्स हैं उनको, डॉक्टर्स को, लैब टेक्नीशियन को भी ट्रेन किया इस चीज के लिए कि वो आइडेंटिफाई कर पाए?
हाँ जी, उनकी भी हमने सेंसिटाइजेशन करी है कि हमने सबको पहले फास्ट ट्रैकिंग कार्ड दिखाए, अपने लैब टेक्नीशियंस को भी, डॉक्टर्स को भी और होम गार्ड को भी। होम गार्ड को इसलिए कि जो क्यू बाहर लगी होती है डॉक्टर्स के ओपीडी के सामने, वो होम गार्ड मैनेज करते हैं हमारे मैक्सिमम हॉस्पिटल्स में। तो उनको ये दिखा दिया कि जो ओपीडी स्लिप के साथ में अगर जिसके पास फास्ट ट्रैकिंग वाला कार्ड होगा उसको आपने सेपरेट रखना है, ताकि जो हमारा टीबी का ट्रांसमिशन है वो भी हम प्रिवेंट कर सके। और उनको थोड़ा सा हमने प्रायोरिटी भी दिया कि जिसके पास फास्ट ट्रैकिंग है उसको डॉक्टर पहले भी देख सकते हैं और वो डायरेक्टली अप्रोच भी कर सकता है लैब के लिए। मतलब लैब वाले जो है वो ये नहीं बोलेंगे कि आप अलग से जो है पर्ची पे पहले डॉक्टर के पास जाइए, उनसे लिखवा के लाइए, ऐसा नहीं होगा। जिनके पास फास्ट ट्रैकिंग कार्ड होगा वो डायरेक्टली अप्रोच कर सकते हैं लैब में।
Excellent. Excellent idea. So what you did was you did a root cause, and what you did was to say that, look, how are we experiencing this problem? So, and then you did it at each step. So let us take a minute and go over what is root cause analysis. It is really about identifying the underlying causes. जैसे आपने डॉक्टर रस्तोगी आपने बोला कि कोई fever से आता है, and I'm an infectious disease doctor. Every day I see patients with fever. Or what people, other doctors or family members do is कि Tylenol, nurses बोलती है, just give them acetaminophen और ठीक हो जाएगा. But what we know very well कि ठीक नहीं होगा, because what we do as doctors is we do root cause analysis. We identify that underlying problem कि उनको urine infection है या उनको skin infection है या उनको TB है या और कुछ है. Identify the underlying causes. Most effective solution can be identified and implemented. We know that if we go to the root cause, we will make that change. And it's typically used when we have to figure out what the problem is and so forth. We need to make sure. Basic questions for root cause analysis. Dr. Pratibha, we have discuss this. What is the problem? Yes.
So problem, it is solving paradigm. It basically a system of causes, which is like here we have taken that TB notification is the problem. So we have to solve it. So problem is clear. Why did it happen? We have to dig beneath. आप सभी ने देखा होगा weeds के बारे में, आप सभी लोग जानते होंगे, जब we grow something, we get these weeds in our plants, near our plants, so we pluck them, but वो चीज वहां पे खत्म नहीं होती. We have to dig them from the root. So it's like similar. You have to take out the problem. You have to go to the bottom. You have to dig beneath the surface. You have to take out the root cause, why it has happened. So you have to dig deep to understand why. So what will be done to prevent it from happening again? You need to understand why it is happening. So again, you are digging deep. So you stop the roots from rotting, and you will understand that this is the cause, and take the measures against and intervention against it, and you will stop it.
Exactly. So your interventions are derived from your root cause. Now, let us say. Yes.
Yeah, Dr. Manoj, I just want to ask one thing. You have showed the process measures. You were talking about the root cause. Yes, and you said that from the root cause, we got to the process measures. So how did that happen? That process, how did that happen? Means you got that there was a problem with the ashas, and then you said, yes, we have to sensitize them. So can you just explain a bit about it?
So going from the root cause to our interventions is where the Pdsa cycle comes in, right? Our process map allows us to see what those root causes are, those individual areas that Dr. Mohan and Dr. Sood were talking about. And what we see is once we see those individual areas that are problems, then what we say is, wait a second, this is a root cause. From that, we derive a set of interventions. And then we say we develop a set of measures that will look at those interventions. And then we track those measures over time. But in order to achieve that root cause, we have to go a little deeper. And I think we have a video that may help us analyze this. Dr. Pratibha, I'm going to play this. Let me see if this works. Can you hear it?
क्या देख रहा था? घर देख रहा था. क्यों देख रहा था? ऐसे ही. पोस्टमैन है? पोस्टमैन है? मैं पोस्टमैन हूँ. तो क्यों देख रहा था? अरे घर रहने के लिए देख रहा था. रहने के लिए देख रहा था? वो पड़ोस वाला चलेगा? चलेगा. ये चलेगा? दौड़ेगा. कितना किराया देगा? जो आप कहेंगे. कितना रुपया कमाता है? रुपया मैंने कमाता, मेरा बाप कमाता. कितने बाप हैं?
Why?
बाप तो एक ही होता है ना. तो बाप को मैं बता कर देना करता है.
Why?
मैं कलाकार हूँ, कला से प्यार करता हूँ. ये कलाबाई कौन है? कलाबाई ने कला एक आर्ट होता है. मैं संगीत से प्यार करता हूँ. घर में रेडियो है? है. कौन सी कंपनी का है? मर्फी है. म्यूजिक कैसेट है? है. कौन सी कंपनी का है? HMV की है. टेप रिकॉर्डर है? नहीं.
So what you see here is the whole idea of whys. So shall we talk about a process by which our DTOs, we can do the whys of how to get to the root cause. Share us the 5 whys. Dr. Pratibha?
I'm here, sir. Yes.
Yes.
So 5 whys is a very beautiful tool. Like you just heard just now, he was asking why, and why. Here we also ask the why. And for example, you say in the process map, you say this is not being done. Why it is not being done? Why there is a shortage of trained staff? So Dr. Manoj, I really want you to help me out in this. Okay, so if I ask you a question, why your staff was not trained?
Yeah, so there was no sensitization done, and it was COVID that did not allow me to do the training.
Right. So you have answered 2 whys in one. because because of the sensitization. Why sensitization training is not done? Because of the COVID-19. It did not allow us to arrange the training session, mass training session, maybe 1 or 2 training session, but not enough to train our staff. So the next question, so we are answering, it is not necessary that we go to exact 5 whys. Sometimes you can get answer in 2 whys. Like for example, here itself, we are getting answer in 2 whys. So the third thing is, when you get the idea about that, yes, there is an issue of sensitization, you will take a cue from here and plan your interventions accordingly. So now the question is, can we train our staff ourselves regarding the TB notification? Answer is yes. We can train the staff ourselves till the state or district organization organizing its sensitization training. We can do it by ourselves. And we see, the idea is we have to plan. We know there is a problem. We have to come to a solution where we can see that what we are going to do. So 5 whys basically help you see through to the root cause. So Dr. Manoj.
Absolutely. So I'll ask Commodore Raman, we have time, we can have our DTOs have conversation with us more. As to, we've gone through a tremendous amount of material and we have gone through process measures, aim statement, we've gone through baseline data. All of this is going to be something that we will be covering over with our QICs. The counselors will be working with our DTOs on this in more detail. So Commodore Raman, from our group, thoughts, comments, questions, and also Dr. Salil, your thoughts, comments, and questions.
Dr. Salil, आपका स्वागत है.
So as they're coming out, I want to ask our DTOs, you have approached this in many ways. What are your thoughts on the notification and how you are going to be able to tackle some of this? I'm seeing some of the comments in chat. It is Dr. Anil Kumar has said, if private doctors, patient are not interested to link with government system. So that is a very good, so that there is a problem. And let's address that in how we can approach that in the Pdsa cycle. Suppose the problem is that private doctors are not interested in approaching the government system. So the question is why? So let us ask a root cause. Why are they not interested? Maybe there might be a lack of awareness. Maybe they think they have to pay money. Maybe they think the quality and wait time is very long. And what you will do is, if you do a simple questioning, and some of those that they are concerned, which is often the case कि मुझे बहुत देर wait करना पड़ेगा government system में, private system में doctors देखेगा जल्दी, पर private system में पैसा भी देना पड़ता है. All of those issues come in. So now you can say that in the government system, what the perception of the patient is that the quality of care will not be there, but they will be free of cost. So we can begin to address that as well. So what I'm saying is that you can work on the whys, and then what you do is you begin to change that perception by going to the private doctors and helping them understand that these are some of the ways we are improving the government system and that patients will not be taken away from you. So Dr. Salil, yes, go ahead.
Dr. Salil, you have something to add?
No, please continue.
Okay. So Dr. Manoj, we will call Dr. Sanat Kumar also shortly. He has raised his hand. So very nice question has come up that what to do if the private doctor is not interested to link his patients to the government system. And this is a real world problem. Okay. So let us start analyzing why. And I will give you solutions as well. The solutions which I have learned from our fellow DTOs who have been associated with us. And also at this point in time, I will request all those DTOs who have been able to cross this obstacle to share their views, share their experiences, share the anecdotes so that the balance can learn. So the problem is, if suppose I am a private practitioner, let me be very candid and ask, what is there for me? It is a government policy, it is a government system. If I add my patient, it will add to your numbers, you will benefit, you will get the bronze medal, you will get the silver medal. Why should I do it? Very important question. So we have to also understand, now I am talking like a DTO, that without that private doctor's contribution, without his cooperation, my movement cannot happen. And I have to find some opportunity, some method of convincing him to come and send the patient to my system. Okay, so there is one doctor, please QICs, I request you to help me out by recollecting the name. He started treating all the patients who were referred by the private practitioners as VIP patients. Okay, because the private practitioner has a grip on the family of the patient with so many years, he doesn't want to lose them. So what the DTO did, he said, every patient that you recommend will be VIP for me. Every DTO owner, yes, of course, Dr. Anil Ajay Atri, he was the one who came up with that solution. Thank you so much, Ikta, for reminding me. So he said, every patient who will come to me will be VIP. Okay. He will continue to take the treatment from the private practitioner. I will make sure that the medicines reach the private practitioner from our side. He then did one more friendship with the private practitioner. He said, you must be getting some poor patients sometimes, those who need to be checked for HIV, those who need to be checked for X-ray of the chest. Okay, you may be in need of some tests which are to be done. Refer those patients to me, I will help them. And there the synergy started between the private and the public. We have to understand, if we have a dependency on the private practitioner, there must be something which we can provide which will help him. Acknowledgement, reward, recommendation. Let it be known clearly. Call him to the functions where you are felicitating TB recommendations from the private practitioner. We get so much opportunity to talk to the press, talk to the media, drop a few names, and this has all been done. This has all been done by the DTOs. And let me see the chat if some suggestions are coming in. Yes, so Dr. Amravati, DTO Amravati says, just to provide the correct information, and it will happen. The sensitization will happen, the response will come. I would share with you the PDSA of DTO owner, Dr. Atri, who did it. In fact, there is another way of looking at it. The private, the patients also don't want to come to the public system. One is the issue that you raised, that the doctor is not recommending. Even the patients are there who may not like to come to the public system. They are happy with the private. So we can take that problem also subsequently. Dr. Sanat Kumar, if you may like to raise your query or add something. Dr. Manoj, if you may like to add something to it. Any DTO, feel free to add, give feedback, comment, amplify, give your suggestions.
Absolutely. So we'll, as we get other DTOs chiming in, I want to be finishing up also with Dr. Mohan Kohli talking about the real world problems and how they affect us, and also Dr. Salil sharing some of that with us. But I'll say this, patients lots of times don't even want to go to a doctor, right? And you have to get them to come to a doctor than coming to a private doctor and the public doctor is there. And these are all our problems and issues that we have to deal with if we are to bring that TB notification rate higher and then subsequently a decline.
Okay,
so
yeah. Sorry, Dr. Manoj, sorry to...
Please go ahead. Yeah.
So we know that there is a TB supporter who's supposed to get the money. The private practitioner can be nominated to be that as well. Okay, so he will get his monetary benefits because monetary benefits matter to everybody, and that's reality. So once he recommends the case, he gets the benefit. He continues to make sure that the patient is getting the medicine. He supports the patient. He keeps getting the benefits. He gets acknowledgement. He gets recommendation. His other patients, they get recommended to you. You offer them the government facility of blood tests, of x-rays and everything else. Develop a synergy, develop a bonhomie. Believe me, it has happened. The PDSA has been done and it has produced results. Yes, Dr. Mohan.
Absolutely great. So just ये अभी जो photos आ रही है इसका क्या मतलब है? We need to understand we live in the real world. We study everything, but everything affects us. What has happened, pandemics, epidemics, hurricanes, natural disasters, economic disasters, right? Everything has a bearing on how we work, what resources we get, what we have to do day to day. And our DTOs have been in the center of this through the last 2 years, and they will appreciate it. They had to play the role of, accumulator on one day and defender on the other day and policy maker on the third day, whereas on the fourth day, they were clinicians taking care of dying patients, right? So they have to wear different hats at different times. And what are these different hats you have to wear? Things can change overnight, right? It has happened. Even today, we are sitting here, we have started doing things, but we are not sure, is the pandemic over? Nahi pata, we don't know, right? It's uncertain. Similarly, you have seen how things have come about together. So many different people are involved, in managing things. It is a complex world out there. We feel it is simple because we are used to handling these complexities in a way that only we can do, right? But remember, there is a scientific way of understanding how to manage, challenging situations, right, Manoj? And nothing more than the next slide. Would you like to take them through this next slide, Manoj?
Sure, absolutely. So I think this is really important concept that we must take time to understand. And it is this: we live in a complex environment. We live in a volatile environment. We live in an ambiguous environment. And we live in an uncertain environment. ये सब चीजें लाइफ की रियलिटी है. ये नहीं होता और ये problems नहीं आती, then life would be incredibly boring at one end, but life would not be life. We know that that is the basics of life. And that is why we are here as doctors to help our patients. हर बार जो different situation आती है, there's a different scientific management proven strategy to solve that. So I'm taking a very, very big picture here for a moment. We went into the depths की अरे notification improve करना है, ये करना है, but उसके ऊपर की आप बात सोचिए. Why we got into all of these problems was because our environment is very volatile. So if a volatile situation is there, how do we address it? It's important that we communicate early, that we ensure your intent is understood. And we learned that that's a whole issue that's there. Second, we need to know that if the situation is uncertain, what do? We get a fresh perspective. We are flexible. We know that that is the approach that will work. If there's a complex situation that is there, what we do is we develop collaborative leaders, other people who may have done this before, and we bring them in. We stop seeking a permanent solution. So, example again, with COVID, we were like, we're not going to solve all of COVID by everyone becoming COVID-free. We're going to manage the patients in the hospital as best we can, right? When a situation is ambiguous, if you are not sure why your TB numbers are not going down, if you're not sure why the private practitioners are not working with the patients and working with you, you have to listen. That is in an ambiguous situation. Listen and begin to think divergently. Socho alag tarah se, soch, out of the box thinking apan bolte hain. This are the solutions, management solutions that will help you, and set up incremental dividends. What will help the doctor, the private doctor, in making things better for him so that he can then make things better for you.
Manoj,
So, yes, please.
Yeah, one trick to understanding ki kaun sa situation kya hai is ask yourself the question, kya problem clear hai? Is the problem statement clear? Is the answer outcoming and very clear, right? If the answer to these questions is no, the problem is not clear and the answer is not clear, it simply means you need to take a deep breath and try to understand where you can get help from, right? And you don't need to do everything what you have been doing. You need to do something different, probably bring in more people and look at things in small doses, set up small wins. That's it for you and the team, because the team is waiting for you.
Got it. Great. So with that, I will have us finish up. I know that we've been here for a good amount of time. Commodore Raman, would like you to share any thoughts from our DTOs or from our faculty. And Dr. Bhargav, we've been through a sort of a huge road race here with baselines, with measuring improvement and so forth. So any comments from your end as well? Yeah.
Thank you. Yeah, Dr. Jain, you saying something?
Yeah, no, go ahead. Yep.
Okay. So thank you, Dr. Jain. And DTO Amravati raised a very important point that we only need correct information from the private practitioner. We will go more in this detail. We will be sharing, I will probably try and bring a couple of DTOs who have worked on this as a PDSA, how to get more references from the private practitioners. If I can't get them, I'll make sure we share their videos with you, that you know what is the technique that they applied. Maybe something will appeal to you people also, because the problem everywhere is the same. And with this, and if nobody has anything else to contribute, I will request all of you to switch on your videos for the photography. And it is time for us to say thanks to all. You've been very patient in listening. Thank you so much. And we thank all the participants, TTOs, your counselors, and the team leads, the staff for this session. Thank you so much.
Thank you, everyone. And we'll see you next Friday. And your counselors will be working with you. And please, again, when they call you, pick up the phone or send a text message if you're busy, that you will be engaging with them at later time. Counselors are young and are public health freshers who are really keen on helping you at every stage. And they know these processes and they know the electronics of how to develop an aim statement, process maps, and everything for each and every one. And we'll be hearing more of those presentations, and we'll do breakouts in the upcoming sessions. So thank you, everyone.